And today we'll talk about the usual 13 topics that I feel are most relevant in urgency medicine. And starting with an interesting case on a 22-year-old female with chest pain, dyspnea, cough, and vomiting. And after that, we'll talk about adjunct occipital nerve block for treatment of migraines, and approach to how select sutures in urgent care wrap. Number three, and then we'll talk about leukocytosis, how to approach that in the acute care settings. And then we'll talk about a series of poolside resuscitation, three parts, including how to approach pediatric resuscitation for drowning, and a picture quiz after that, and bladder pain syndrome, which was previously called interstitial cystitis. So in the interesting case, there are 22-year-old female patients present with chest pain, cough, dyspnea, and vomiting, and symptoms began after choking on the first bite of food at the restaurant. She was talking while eating, began choking, and her father performed Heimlich. She then vomited immediately and continued retching during transport. On arrival, she had substernal chest pain, dyspnea, and odynophagia, with an inability to tolerate liquid due to pain and vomiting. Persistent vomiting and chest pain after choking is not typical. From physical exam, vital sign was normal. She was in mild distress only and actively vomiting, but no hematemesis. Lungs, cardiovascular exam, abdominal exam were all reassuring in EKG. However, because of persistent symptoms with chest pain and vomiting, chest CT was ordered, which showed an esophageal tear. So there's a classic triad of esophageal perforation with severe vomiting, chest pain, and subcutaneous emphysema. But in only 50% of less than 50% of patients, pressure, vomiting, Valsalva maneuver, and in this case, a choking incident. Milery-wise, include bloody vomit with injury to the lining only. Boerhaave syndrome has full thickness injury and rupture, and in this particular case, that's the diagnosis for this case, Boerhaave syndrome injuries. Systemic symptoms due to mediastinal contamination, such as fever and chills. Cervical perforation, dysphagia, and pain in neck flexion pain. Distal esophageal rupture leads to leakage into peritoneal cavity, causing peritonitis, but diaphragmatic irritation and refer pain to shoulders. Labs are not helpful. Chest X-ray abnormal in 90% of cases, and pneumomediastinum or subcutaneous emphysema. The V sign or air outlet in the left medial hemidiaphragm and lower mediastinal border with free air on the diaphragm, and also pneumothorax. So depending on the location of a rupture, the symptom could be different, neck or chest or in the upper abdomen. CT with IV contrast is 92 to 100% sensitive, and it also helps with alternative diagnosis. For management, to emergency department, supportive plus broad spectrum antibiotic covering for gram-negative and gram-positive and anaerobes, such as augmentin or carbamox, amoxicillin. Minimize nausea to avoid more vomiting, which can aggravate injuries. PPI, NPO, definitive treatment, usually surgical or interventional radiology. So Boerhaave syndrome, one of the main diagnoses for esophageal tear. Next topic is paper regarding adjunctive occipital nerve block for treatment of migraines in cephalagia in 2025. Study of 42 patients randomized and completed the study. Control group of migraine cocktail, ketorolac, paracetamol, which is similar to acetaminophen, and metoclopramide versus the treatment group that include the above cocktail and also greater occipital nerve block. The key outcome of interest was proportion of patients with pain score decrease of at least 50% in 1 hour. So the results show 95% of the intervention group achieved the primary endpoint, whereas just 47% of the usual care group. On follow-up phone call in 30 days, the intervention group has significant fewer headache days than the usual care group, 3 versus 7. A low rate of emergent ED recidivism, 9.5% versus 23% for the control group. The study's main limitation includes small sample size, open label. However, evidence supporting greater occipital nerve block in acute migraine treatment continue to mount. Whether to use steroid in a cocktail with Lido, no epi is a question unanswered. If anyone wants to learn how to do the greater occipital nerve block, come find me at Worcester ReadyMed Plus. I do this routinely, almost on a daily basis at Plus. Approach to how to select sutures. Urgent Care Rep, March 2026. 3 key factors when choosing sutures. tension across the wound, cosmetic importance of location and tension, cosmetic, and also likelihood of follow-up for removal. Non-absorbable sutures, follow-up is reliable, and cosmetic control is important. Face, hand, extremities. Absorbable sutures, ideal for pediatric patients, fast absorbing for 4 to 5 poor follow-up on reliability, mucosal surface, oral cavity, nail bed to avoid painful removal and preserve nail matrix. So those are more ideal for absorbable sutures. Suture size in general, the smaller the size, the more sutures, the better the cosmetic outcome. Also check your work to make sure wound looks good and correct any uneven wound edges as you repair wounds. For a 4 suture size in high tension area, thicker skin, scalp, trunk, extremities, joints. 5 lower tension wounds than above, such as in the hand, not somebody that work in construction, for example, on the face and so on. 6 on the face also. Takes more time, but best cosmesis, face, hand, dorsum, vermilion border. Next topic, approaching leukocytosis in Care Wrap, February 2026. So leukocytosis does not always include bacterial infection. Clinical decision-making should be based on history of physical, not isolated lab values. Physiologic leukocytosis, pregnancy, newborn, infant, recent trauma, pain, vomiting. Other causes such as infection from a viral, fungal, bacterial, inflammation, trauma, malignancy, and medication can also cause leukocytosis, such as albuterol, beta blockers. When to worry about leukocytosis? Most concerning when white blood cell count is extremely elevated, over 100,000, paired with red flag symptoms such as night sweat, weight loss, organ dysfunction. Even in suspected malignancy, ED transfer is not necessary unless there is evidence of organ dysfunction. Urgent outpatient hem-onc follow-up is appropriate. One time I've seen a C. diff colitis with a white count 80,000. So C. diff colitis, especially in younger patients, can cause pretty severe leukocytosis. So again, physiologic leukocytosis, pregnancy, newborn, recent trauma, pain, vomiting. Seen a lot of that with patients vomiting. Right? Other cause, viral, fungal, inflammation, trauma, malignancy, and meds such as steroid, beta agonists, beta blockers. So consider those before making a decision to give antibiotics for well-appearing patients. For a well-appearing patient with leukocytosis, you can start to determine if this is from potential serious infection. Next day's close follow-up or reject is a very reasonable option. Differential, neutrophilia, bacterial infection, lymphocytosis or monocytosis, usually viral, and eosinophilia, allergic or parasitic, fungal. Poolside resuscitation, the case on RAP. So the author of the article, an ER physician at LA City, USC, was at the pool with her 2 children ages 3 and 5 who were taking swim classes. Suddenly she heard a loud whistle and saw the lifeguard jump into the water and pull out an adult male to the surface onto the edge of the pool. She ran to the poolside, introduced herself, and offered help. The person was cyanotic and apneic and not moving spontaneously. There was no pulses. The physician started compression within 2 seconds of him being pulled out of the pool. With the first compression, water and white foam started pouring from his nose and open mouth, and more came out with each compression. Another lifeguard arrived with a one-way valve mask and started ventilation. After a period of time, they stopped and did a pulse check and still found nothing, so they resumed CPR. They stopped compression, but it was not clear if the pulse was present, so resumed CPR. A few minutes later, the victim regained spontaneous respiration and a pulse. Victim was rolled onto his side to evacuate foam, emesis, and liquid from his oral airway. The physician was sweeping his mouth with an ungloved hand. An oxygen tank arrived and an oxygen mask was placed over his face and continued to intermittently clear his secretion. The physician then gave a report to EMS and sent him off to the ED. So apparently the victim were doing free swimming while his 2 children, ages 7 and 9, were taking swim lessons. Suddenly, among the loud chaos with all the swimming students, people overheard the kids screaming, "Daddy, wake up! Daddy, wake up!" On the way home, the physician called a local hospital and talked to the treating physician at the hospital, and the patient was awake and talking to his family, but was hypoxic due to significant pulmonary injury and was on high flow oxygen while being admitted to the ICU. So that's part 1. It's about an interesting case. We'll get to part 2 about lessons learned and part 3 about the pediatric approach to pediatric drowning. The next topic is don't get flops. Beware of fluoroquinolone risk. RAP March 2026. The informal term flux is describing persistent multi-system symptoms after fluoroquinolone exposure causing FQAD, fluoroquinolone-associated disability. FQAD poses a medical legal risk. A fluoroquinolone mechanism of action include attack DNA gyrase causing oxidative stress, and it chelates calcium, magnesium, and iron, causing impaired collagen synthesis and tendon integrity. It increases matrix metalloproteinases, leading to connective tissue degradation. GABA antagonistic is another mechanism of fluoroquinolone, and this can lead to neuropsychiatric adverse side effects, including agitation, seizures, and cognitive impairment, and especially in those with reduced GFR, anti-GABA effect. Tendon rupture or tendinopathy, especially with concomitant steroids. C. diff colitis, one of the highest risk antibiotics. Aortic dissection or aneurysm, probably same mechanism as tendinopathy. Peripheral neuropathy, severe hypoglycemia when combined with sulfonylurea, such as glyburide. Myasthenia gravis flare. So recommendation, last resort antibiotic for the following conditions: bacterial sinusitis, COPD exacerbation with lower respiratory infection, UTI, community-acquired pneumonia, soft tissue infection, and diverticulitis. Try to avoid in the elderly, especially those with CKD3 or worse. Concomitant steroids, tendon rupture, those with history of CTD, connective tissue disease, aortic aneurysm or dissection, or peripheral vascular disease. Share the risk with patient before prescribing. For the next topic, that's why I no longer see most of us now prescribing fluoroquinolones due to such a high risk. Picture quiz about cervical mass on American Family Physician. 59-year-old postmenopausal woman presented for a routine gynecological exam. She reported mild dyspareunia but did not have dysuria, hematuria, or pelvic or abdominal pain. She experienced no uterine bleeding since completing menopause 4 years earlier. Her last pap smear test was negative for HPV but showed atypical squamous cell of undetermined significance. Specular exam revealed a fleshy mass 3 centimeters in diameter protruding from the cervical os. What was the diagnosis? Was it cervical carcinoma? Was it a polyp, cervical polyp? Was it endometrial carcinoma, endometrial polyp, or was it a prolapsing submucosal fibroid? And the answer is endometrial polyp. They are localized proliferation of endometrial gland and stroma that develop within the uterine cavity, can range in size from a few millimeters to several centimeters. Most common between the age of 40 to 49. Risk of malignant transformation is reported to be as high as 13%. The patient underwent saline infusion, sonar, hysterography, and hysteroscopy, which verified the finding. Excision demonstrate a complex polyp originating from the left lateral uterine fundus, confirmed to be benign endometrial polyp with no hyperplasia. Next topic is bladder pain syndrome from American General Family Physician, April 2026. The definition is 6 weeks of intermittent pain localized to the bladder, but not attributable to any other pathology. Prevalence between 0.8 to 0.9% in the US. Why is it important to know? It's good to know about a patient with this diagnosis, potential diagnosis, to reduce the risk of prescribing inappropriate antibiotics in these patients. If you look at culture, multiple cultures that have been negative, they've been giving antibiotics and symptoms keep returning, even though they got better, or sometimes they don't get better. Then you have to wonder about this. So the pathophysiology, urothelial damage, central pelvic sensitization, and Hunner, Hunner, Hunner lesions, which can be seen on cyst and pathognomonic for bladder pain syndrome. Symptoms include dysuria, pressure or discomfort associated with bladder filling, urinary urgency, nocturia, and dyspareunia. Triggers for flare-up include diet, stress, intercourse, and exercise. Residual. Cystoscopy may be useful for biopsy discomfort. Treatment is cognitive behavioral therapy, yoga, mindfulness-based stress reduction, show significant improvement, support. So keep that in mind. Bladder pain syndrome or interstitial cystitis. Make sure you check for culture before treating. Also look for systemic symptoms. See if there is any other healthcare professional to help retrieve the oxygen. The psychiatrist also were instrumental with debriefing the children afterwards. He also checked in with the victim's wife when she arrived. This was a traumatic experience for everyone, and the physician was probably the only person that had witnessed a cardiac arrest victim. Take time to process the event emotionally for self and loved ones if they also witnessed the event. get support if needed to help deal with the emotional impact of this event. The victim dropped and died in 3 feet of water with lifeguard only 15 feet away. That's lesson number 2. Drowning can happen very quickly. Apparently, it was later found out that the victim liked to see how long he could hold his breath in underwater. He may have passed out or taken an involuntary breath. I have done this before with my children, just trying to hold our breath, and the lifeguard didn't seem to be very fond of that. Number 3, in drowning victims, oxygenate first. Most of these arrests occur due to hypoxia. Oxygenation is key, unlike in cardiac etiology, cardiac arrest. Perform CPR with breaths to give respiration, since oxygenation is important. That's lesson number 4. Do 30 compression and 2 rescue breath. There was a lot of mouth secretion as a result of the compression, so one could consider turning the victim to the side briefly to evacuate the secretion before rescue breath. Number 5, should we use AED? Victims are wet, so make sure only use after drying them off to reduce risk to rescuer. Oxygenation is more important than AED in drowning rescue. Also, consider C-spine protection rare for those with considerable trauma. And also, we warm up victims since exposure to cold water and can cause hypothermia. So, do not pronounce patients until they are warm and dead. Next topic, approach to systemic sclerosis or scleroderma. I just list here things that signs and symptoms of systemic sclerosis: skin thickening, hyperpigmentation, hand edema, non-pitting hand edema, Raynaud phenomenon, which is very common, 95-97%, telangiectasia, which is look like a spider, veins, ulcerations of the skin, and the GI include dry mouth or esophageal dysmotility, and then musculoskeletal include arthralgia or myalgia with tendon friction rubs, and then pulmonary include dyspnea. So a variety of systems with multiple symptoms. For lab, do CBC, anemia may be second to malabsorption, kidney disease, iron deficiency, GI blood loss, BMP, CK to look for evidence of myositis. Autoantibodies, ANA elevation in more than 90% of those with SSC, and anti-centromere antibodies in about 30%, anti-RNA polymerase antibodies, and anti-topoisomerase 1 antibodies. Next topic, association between oral corticosteroid burst and severe adverse side effects. In Urgent Care Rap, January 2026, studies at 15,859 patients aged 20 to 64 who were prescribed steroid bursts, which were defined as less than 14 days or less. The odds ratio was 1.8 for GI bleed, 2.0 for sepsis, and 2.37 for heart failure. 30-day post-treatment for the group receiving steroid bursts. The result maintained across several subgroups with risk elevation similar in patients with or without comorbid conditions. Application to ReadyMed care. Monitor sugar in high-risk patients. A1C more than or greater than 6. High-dose steroid. Prior gestational diabetes. Family history of diabetes. Older age and high BMI. A test insulin dose may be needed. Watch for neuropsychiatric effects such as mania, depression, psychosis, suicidal ideation with the highest risk in the elderly, and insomnia. Venous VTE risk, possible elevated risk, use with caution in those that are immobile, post-op, or high VTE risk patients. Vaccine, delay vaccine for more than 1 month after more than 14 days of prednisone course. Risk to bone health, weigh the risk of recent fracture or healing bone. Consider alternative treatment. Adrenal suppression, taper if more than greater 14 days or greater for a steroid course. So it's not harmless. Try to minimize the duration if possible, and beware of those with history of hypoglycemia or diabetes and the elderly due to risk of GI bleed, sepsis, heart failure. Not insignificant. Epiglottitis, next topic. Urgent Care Max, March 2026. The case is 37-year-old male presented to the urgent care with sore throat, temperature 100.8, heart rate 115, respiratory rate 20, oxygen level 97% room air, and blood pressure normal 135/82. He does appear ill, hunched over, shivering, hoarse voice. Symptoms progress rapidly, starting day prior with severe odynophagia, raspy voice, and mild dyspnea. I think that all of us know that this guy needs to be stabilized very rapidly with EMS being contacted to come as soon as possible. His airways at risk. PE, no exudate, no tonsillar swelling or trismus, and only mild posterior erythema, mild bilateral anterior cervical adenopathy, and clear lungs. Teaching point is a symptom more concerning than physical exam. Deep tissue serous pathology such as necrotizing soft tissue infection and compartment syndrome have to be considered. Horse pathogen now more likely strep and staph, since H. flu less common due to vaccinations. Primary cause of death is airway obstruction. For diagnosis, the gold standard is direct laryngoscopy, CT neck soft tissue with contrast, or subneck X-ray. Soft tissue neck X-ray, if CT is not available, show thumbprint sign, blunted swollen epiglottitis. Management outcome: ED transfer, monitor, ENT, IV antibiotics with muscle coverage, no intubation. The patient will discharge home after 3 days. There's some pictures here of X-ray on epiglottitis and also tracheitis. The last section is on poolside resuscitation, part 3, resuscitation after drowning infusion. Updated from AHA and AAP, account for 1 in 14 unintentional death worldwide. The leading cause of unintentional death in children less than 5, and second leading cause in children ages 5 to 14. For preventable action, 90% of drowning are preventable. Top 5 preventable action: 4-sided isolated fencing around a swimming pool, approved life jackets, swim lessons, especially for children and non-swimmers, lifeguard supervision, close supervision of weak swimmers and non-swimmers in and near water. Recognize distress and provide flotation. Approach a drowning victim in the water can create a second victim if the panicking person pushes to rescue them down. Worst case scenario, if that happens, you swim under the water. They will let you go, and then you go back up. We're going to try to get something to throw to them, a flotation device, if possible. Remove from water when safe, horizontal if unconscious, and vertical if conscious. Provide BLS and ACLS. Less than 1% of drowning victims involve cardiac arrest. For a long time in the water without rescue breathing can lead to cardiac arrest, however. In water rescue, breathing when appropriate has shown more favorable survival rate and neurological outcome. Rescue breathing is essential in any resuscitation effort, since hypoxia is the immediate consequence of drowning, and rescue breathing is prioritized over the use of AED with or without chest compression. I hope you find it helpful, and I know it was fast, but it was a lot of material. I apologize for the speed, and if you have to listen twice, please do. It's only once a month, so I hope you find it helpful. Give me feedback. Let me know if I can do something to improve this monthly podcast on ReadyMed update topics. Take care, everyone.